Good morning.
Good morning, Carolyn.
It is nice to see you.
You too, Carolyn.
Always.
You too, Carolyn.
Okay. So we have lots of questions and we're going to get to them.
All righty.
Okay. Number one. Woman writes in, I cannot take HRT or any form of HRT. I don't know how to pronounce this. Due to a meningioma.
Yeah.
Wondering your thoughts on this. I've seen many doctors and all of them say no to hormones. No way. Are there any alternatives or any thoughts that you can give me?
This is a challenging topic because anyone who Googles, do hormones play a role in meningioma, comes up with information. The first time I ever got exposed to that has been very recently, that information. And I actually went into some of the scientific articles that speak about a possible relationship of meningioma to hormone replacement. Well, really, the angel is in the details.
Mm-hmm.
Because scientific studies can be anywhere along a spectrum from being really fabulous science, great information, extremely helpful and extremely relevant at one end of the spectrum. And at the other end of the spectrum, there's junk science. I mean junk. And that junk stuff exists because someone's trying to push an agenda, usually an economic agenda. So some new drug is put through studies and they find very favorable results, but the information has been faulty, the study was faulty. This is such an important issue in medical science that as a senior in medical school, we had a 6-month course in the medical literature. That's how much the University of Michigan thought about that subject. And their whole purpose was to get us to be able to be discriminating. And all these scientific studies, when they're published, they all have the same format. So they all look like this, they all look the same. But it's the angels are in the details. If we go into a deep read, you have to understand a lot about science to even know if this stuff is valid or not.
Right.
And my quick perusal of that association between meningioma and hormones, which doesn't make a lot of sense, was that, whoa, this is marginal science, and I don't see this really clear-cut causative relationship between hormones and meningioma. Now I'm going to make a more dramatic statement called hormones don't cause cancer. Hormones are some of the most powerful and protective and beneficial biochemicals in our body. Cancer has causes, absolutely. And then whether or not these powerful biochemicals can facilitate the growth if the cancerous changes take place, that's a whole other issue. We know the most about that in breast cancer, and that's a very gray area. There's, as far as I can tell, no one can prove the point that even if you have an estrogen positive receptor site, breast cancer, or I'm going to put it another way, you have a breast cancer that on biopsy or surgery shows that the presence of estrogen receptor sites, even that area is very gray as to whether if that woman is treated with hormones that she's going to get an accelerated growth or a recurrence of the cancer. And the best information that I have is that women who have been treated, women who've had breast cancer, have been properly treated for that breast cancer and adequately treated for that breast cancer, they do have an increased rate of recurrence for that breast cancer as opposed to a woman who's never had breast cancer getting breast cancer. But that rate of recurrence is less if the woman was treated with hormones than if she is not. And the medical doctor that's done the only study that I've seen that really has some tremendous validity to it, Dr. Avram Blooming, he points out that in the beginning of his study in the early 2000s, they didn't have a lot of information, or even in the 1990s, they didn't have a lot of information about receptor sites. And so these women who had breast cancer properly treated and were treated with hormones, they didn't know anything about estrogen receptor sites. But the statement that they could make was that women who had that breast cancer properly treated were at less risk of recurrence if they were treated with hormones as opposed to if they were not. And the hormones they were talking about was Premarin and Prempro. I'm not going to go into that subject right now, but I think that's highly relevant. Now I'm going back to the meningioma. My brief and incomplete perusal was, there it is again. What is the point they're trying to make, and what kind of statistics are they showing here, and do they show cause? And I didn't get it. But let me approach it from a different angle. Men and women who are midlife and beyond have substantially / dramatic declining rates of, in men, testicular hormones, testosterone, and women, ovarian hormones, 4 different hormones. That's for sure. And here's another thing. There are dire consequences of that over the long haul. And I've told this story before in our Facebook Live, but I'm a senior medical student sitting in an afternoon lecture in the University of Michigan Hospital. And today's lecture, that was a long time ago, that lecture was by a gerontologist, a specialist in aging and treating elderly adults. And the gerontologist said to us, I can picture it as just like I can picture you right now, Carolyn, because it was so startling to me. He said, "You're senior medical students. You know thousands of diagnoses. Let me tell you what's really happening with older people. They're losing their muscles and they can't stand and walk with stability. They fall onto osteoporotic hips and they die."
And they did.
And what did I take away from that? Why in the heck is that happening? Why are they losing their muscles and getting osteoporosis? And the number one top of the mountain for causing osteoporosis and sarcopenia, which is muscle loss, is low hormone levels. The bones relate to the ovarian hormones tremendously. You lose that estrogen, for example, and that progesterone, you lose bone. And there's an epidemic of osteoporosis in elderly women. Absolutely. And then how do you lose the muscle? You lose this crucial female hormone called testosterone. Testosterone is not a male hormone, it's a human hormone, and women need it for women reasons as much as men need testosterone for male reasons. And one of the main reasons is for the preservation of your muscles. You need testosterone, and when you lose testosterone, you wind up losing your muscles. So take a look at the thighs of many normal weight elderly folks. They're very much thinner. And why are so many women and men in assisted living facilities and nursing homes? One of the main reasons is they lose their muscles. So they can't walk with stability. They get into walkers, and boy, when they cross over to where they need wheelchairs because they can't walk with stability, it's assisted living and nursing homes for those who can afford it. They also lose the muscle that holds up the bladder for women. That means you get urinary incontinence, and you get adult diapers. And these are the principal reasons why women are in assisted living facilities and nursing homes. So why am I saying this? Is there a risk of getting meningioma from hormones? Like I say, and I stand very strongly on this, hormones don't cause cancer. And what is incumbent and crucial for this questioner is that she go in or gets the assistance of a professional to really examine that meningioma risk literature. Because life, in one way of looking at it, is a day-to-day assessment of risks and benefits. There ain't no thing in life that doesn't have risks. This is not a risk-free existence on this planet. I have personally discovered this. I don't know if anyone out in the audience just believes that or not, but I don't know how many risks I face today. I've already faced a couple of them and benefits. So I want to blur this questioner and say, you've got some research to do because there's a near certainty of dire consequences from low hormone levels. And they never stop and they always get worse. The older you get, the more bone you lose, the more muscles you lose until you can't. For many people, not everyone, you see occasional 90-year-olds that are walking okay and thinking okay, but they're the rarity. So there may be increased risk for meningioma. I just am not expert enough and didn't. This is not a priority that I can put a lot of attention to with my commitments to really study that. If someone was in our program, we would sort that out for you. But is there risk with meningioma and hormones? Well, let's say there's a near certainty with no hormones or low hormones.
Right.
So you as an individual, and unfortunately, a rumor gets out in the medical literature that meningioma is related to cancer, and doctors pick up on that, and that's what they remember. But you've got to look in medicine at the big picture. The angel is in the details. You got to really hunker down and answer this question. If you put 40 hours into it, or maybe 4 hours into it, questioner, you're going to come up with your own conclusions. And if you need a little help, there's health professionals that could help you do that review of the literature and really assess what's the risk of meningioma and hormones aggravating it or causing it versus the certainty of osteoporosis, sarcopenia, and everything else that you lose when you lose your hormones. So I cannot answer your question directly. I know I've been very circuitous about it, but I can tell you this. These things always proceed by one foot after another. And your first step is hunker down and really understand that meningioma literature yourself. We'd have to know a lot more about your individual case, by the way, to really weigh in it, because there's the general stuff and then there's the specifics of who you are and what you got going on. And then weigh that against the near certainty of the dire consequences of running low on hormone that just get worse after year after year after year. And having dealt with women in their 80s and 90s, these are not pleasant, and your life is going to matter as much to you then when you're in your 80s and your 90s as it does right now in this very moment. So, questioner, amazing question. Hunker down and keep going until you get that answer, because what will happen if you really do your due diligence, if you really put your effort into it, somewhere along the line, you're going to get an answer of what's correct for you. And it's going to come down to, yes, I want the hormones, or no, I don't. I feel this is too risky. I don't want to assume that risk. It's going to come down to yes or no. It's not going to come down to maybe. It's not going to come down to gray. This happens in any area of life where we've got a question and we're uncertain, but we do a lot. We really put our shoulder to the wheel to really effort to get the answer. And if you do that, you're going to get an answer, and it's not going to come down to maybe. It's going to come down to yes for me. I know what I want to do here. I want the hormones, or no for me. This is too risky with everything I've learned about meningioma and who I am and what my individual situation is. Yes or no. Keep going. It's too big of a subject to not do that. And you don't get to know that. That's the thing. I'm a medical doctor. I see people of all ages, from in the womb to in their 90s. So I get to sneak preview about what's going on in the 80s and 90s. And for most people, it's not something you're going to want. So this is research worth doing. You feel pretty good now, so you say, well, I don't, I'm a little low on hormones, and I don't really have to do it because you're walking and talking and you're feeling pretty good. Yeah. Well, the consequence of long-term loss of hormones is a big deal. So you want to weigh all this stuff.
Okay. Well, thank you. A question did come in. Sylvia says, can she continue BHRT while being treated for estrogen breast cancer?
That's not an answer that I'm willing to give right now over the air.
Okay.
I mean, these kind of situations, everything has to be taken into account, including details about the individual patient. I mean, we have our discovery process in every initial consultation where all we're doing is learning about a woman, and this is we need to know the technical details, a lot of details from this woman. But Sylvia, read Estrogen Matters.
Please.
That's your homework. You need to personally get a sense of what is this breast cancer, what are the risks, what is the relationship to hormones. And Avram Blooming, an oncologist, a specialist in breast cancer, and his wife and daughter had breast cancer, so it's been really up close and personal to him. And he's done the most significant study I've seen on treating women who've had breast cancer with hormones. And he started treating these women long before the receptor sites were really understood. I communicated with him personally about this. So a lot of women out there have been treated. But your homework, Sylvia, is to read Estrogen Matters by Avram Blooming and Carol Tavris.
Great book. Okay. Question number 2. My doctor wants to give me a starting dose of progesterone via the micro pill, 200 milligrams. This seems quite high to me, and I'm wondering what your thoughts are on this.
I think there's not full understanding of the information involved here on this questioner's part. And when I hear the word micropill and right followed up by 200 milligrams, my guess is her healthcare provider is talking about micronized progesterone, which is a compounded bioidentical hormone. And so I don't think it's a, quote, micro pill. I've never heard that term ever, so associated with hormones or anything else. But micronized progesterone, micronized is a good word to associate with progesterone. It's very common because that's the kind of process that you want that has to do with compounding the proper progesterone into a capsule for oral use, micronized progesterone. Now let's talk about progesterone dosage. When you're taking it orally, in my practice, women come in at their final dosage somewhere between 75 and 225 milligrams, most commonly. Wow, that's a range. 75, 225, that's 3 times the low end of normal, because this is the way the human body works. We look the same, sort of, but we're deeply individual, right down to the biochemistry, and there's a wide range of what the right dose is for each woman. So some women are taking more than 225, and some women are taking less than 75. I just give you the most common range in my practice. So 200 milligrams is a robust dose, but it's not even at the top of the mountain there. So I don't know that there's reason for concern, but I do suggest that you download our book off Carolyn's Ins and Outs of Menopause Facebook page. It's called Happy Healthy Hormones, and we very clearly describe, we give a lot of information about progesterone, and we very clearly describe symptoms of progesterone overdose. Like, progesterone is the great calmer.
Mm-hmm.
So if you take too much progesterone, you get too calm. You usually take progesterone at night, oral progesterone at night to help you sleep. So if you take too much, you wake up like you're drunk, like you're groggy, like you took an overdose of a sleeping pill. It's not pleasant. So 200 milligrams, no way someone can tell me that for everyone who takes 200 milligrams, I know whether that's the proper dose or not. we do a dose discovery process. We start low, usually at 50 milligrams, give it to a woman at sleep time, see how she sleeps. If that doesn't work, we increase her to 75 milligrams. If that doesn't work, we increase her to 100 milligrams, et cetera, et cetera, et cetera, increasing by 25 milligram increments all the way on up until she gets overdosed. Until one morning she wakes up and she feels like she took a sleeping pill the night before and she feels a little groggy or wobbly. Then we back that dose down. That's called the clinical method of determining dose, or dose titration. Start low, gradually increased, hopefully to alleviate symptoms of the hormone inadequacy, while backing down from or falling shy of symptoms of hormone overdose. So that's how we proceed. And 200 milligrams, it's not an uncommon dose. The pharmaceutical manufacturers, I think in response to loss of market share, when so many women were being prescribed compounded bioidentical hormones, one of the first, quote, bioidentical products they came out with, there's other stuff in that capsule. One of the first ones they came out with was micronized progesterone in a capsule. It's called Prometrium. What did they choose as their dosage? Did they choose 15 dosages? No, they didn't. They chose 2 because it's too challenging to market a multitude of dosages, or so they think. And the 2 dosages they chose were 100 milligrams and 200 milligrams. And they chose that for reasons, because that was the most likely amount to balance the estrogen so they don't get overgrowth of the endometrial lining. 100 milligrams and 200 milligrams. So you're on 200 milligrams, questioner. So nothing's bad here. And my guess is everything's just fine. And you may have to read our book. You may be able to identify, well, it's a little bit too much. I think I want to back down some. And hopefully your healthcare provider would be delighted to switch the doses on you. But I think micropill is not the thing. It's a capsule, and it contains micronized progesterone.
Thank you for explaining that. I didn't understand micropill. Thank you. Great answer. Question number 3. It's strange. Estradiol is increasing my libido. How can this be when everybody else says it's testosterone that is responsible for the increase of libido? My testosterone is considered low, with my free T at about 2, and I'm confused. And also, can too much estrogen cause saggy skin and dry vagina? Thank you.
I want to back up to the beginning of that question. I'll start with the end. Estrogen is an amazing hormone. It affects so many cells, tissues, and organs in a woman's body. And skin is one of them. And why do young women's skin look so amazing at times? It's estrogen, folks, and a lot of it. And one of my first exposures to that was I learned that decades and decades ago, the French were putting estrogen in their expensive skin creams and just not putting that on the label. They knew that. This has been known for a long time that estrogen is fabulous for the skin. So what happens when you don't have enough estrogen? Skin changes and thin, and saggy is another part. Saggy can be from loss of the underlying muscle due to testosterone insufficiency. Both of them play a role there, but let's go back to libido. Number 1, how fabulous that something increased your libido. If you want libido, I mean, in medical terms, we call that a miracle. And there's so many elements of libido. Human libido has got so many moving parts. As far as the biology of libido goes, the hormones are at the vanguard of what matters to libido. And for women, all of the hormones can play a role in libido. And it differs woman to woman. Most common I find that of the hormone, they all matter. There isn't one hormone that matters. They all play into feminine libido. In some women, it seems like testosterone plays a more obvious role because when they replenish testosterone, their libido comes back. In other women, it seems like the principal leader of improved libido is actually the estrogen. So, no surprise at all. That's commonly known amongst those who are doing this work every day professionally. Estrogen matters. Holy mackerel, does estrogen matters for libido. There's some women that the leading hormone as far as relation to libido is progesterone. I had a patient once who had a lot of libido, and we had to get her progesterone right within the therapeutic window. Not too little and not too much. If she had too little progesterone, libido gone. If she had too much progesterone, libido gone. But when we got it right in the right individual amount for her, libido, rocking. So they all play a role in libido. They're the most powerful biochemicals that are related to libido. There's other biochemicals that relate to libido, neurotransmitters, for example. And how many moving parts relate to libido in the emotional and mental and friendship and trust and caring and everything that love is world. Holy mackerel, libido. It is the top of the mountain built upon so many important things. But hormonally, any one of those three can be the leader, but you need them all and you want them all. And you want to get them right and you want to get it individualized for yourself. And back to the miracle you have of restored libido. Good for you.
Well, what
Well, what
about
about
estrogen
estrogen
causing
causing
dry
dry
vagina?
vagina?
Thank you, Carolyn. 100%. When women lose their estrogen, I don't know if there's an instance, I have heard of an instance or two. Extremely rare. So I'm going to say at the 99% level, in my wild guess, 99% of women, as they lose their estrogen, their vagina changes. A young woman's healthy vagina is totally dependent upon adequate estrogen levels, among other things. And as that estrogen starts to decline, the vagina undergoes major changes, so much so that anyone who does pelvic exams for a routine professional in their profession, you can spot low estrogen in a flash. And the best way to do it is to take a look at the health of the vagina. Because when the estrogen declines, the vagina gets thin, loses its folds, gets dry, and it is so obvious. And it happens, I'm going to say at the 99.9% level. You lose that estrogen, you're going to lose that vagina. And how it shows up in women is if they're having intercourse, that they start having to use lubrication. That is the sign that you're getting vaginal atrophy. It's not just, it's significant. And then they start having pain on intercourse because the vagina gets so dry and even the lubrication doesn't help. One of the markers of sufficient estrogen levels in a menopausal woman that we're treating is the restoration of decent vaginal health. And I did use the word restoration. So even if you have dry vagina, even if you have significant vaginal atrophy, with good treatment, that will restore. It may not restore to 20-year-old levels. Absolutely pleasurable again.
Interesting. um, Ladies, if you're with me, sorry, gotta find Dr. R. Hang on.
There we go. We're back.
Here we go.
We're back.
I'm going to have to repair the whole internet, I think. Take that project on. I'll get out my toothbrush and start cleaning it up.
And I'll get out mine.
And we can meet halfway in St. Louis or something. You're
Perfect.
in LA, I'm in North Carolina. We'll clean up the internet and we'll meet in St. Louis for lunch.
I will have a green screen. Everything's going to be different.
That'll do.
That's going to make it perfect
That'll repair the World Wide Web.
for everyone. Okay.
Let's go back to dry vagina. It's such a amazing indication of estrogen levels, by the way. I know for certain that when a woman has vaginal atrophy, we're getting a little echo.
I'm not talking.
I know, but we're still getting an echo. Let's see. When a woman has dry vagina, we know her estrogen levels have dropped below that amount of estrogen it's going to take to protect her bones. How do we know that? Because the pharmaceutical industry, when they started getting on the process of developing their own version of bioidentical hormones, they're about 20, 30 years behind. They did some really important studies with estradiol. They were asking the question, well, if we put estradiol in a gel, how much do we need? What's the right dose? And they did a scientific study on trying all kinds of different dosages, and they learned the least amount it takes to protect the bones. And that happened to be the same amount that protected the vagina or restored vaginal health. And so we know what those numbers are. And when we do 24-hour urines on women that we're treating with estrogens, we know the range that they have to be in. We know the lower limit. And at the lower limit, which it happens to be a certain number, it takes at least that much estrogen in a woman's body to protect her vagina and her bones. At least that much. But I can tell you this for certain. If a woman has dry vagina, she's below that limit. So if you're starting to use lubrication and never needed to use it before, you are hovering on that limit and you may be below. Moral of the story, do the job that is the number one job that every woman in perimenopause and menopause is called to do from my perspective. It's to go shopping until you find a healthcare provider that has studied, has a knowledge base and experience in treating women in menopause with compounded bioidentical hormones. That's your job. There's so many technical moving parts. I mean, it's quite a process. Our team is efforting to make it a board certified specialty because standard of care is needed here, and it doesn't exist in this wild west of treating women. There's all kinds of stuff that's being done that is outside what's acceptable for me, from my medical opinion. So the thing is, you want to find someone who's trained in treating women in menopause and is experienced or is being mentored. So dry vagina, yes, it's from too low estrogen. Now the other hormones do play a role in the health of the vagina, and sometimes they're even added to the programs to assist the woman's vaginal recovery. And here's the other part: the vagina will recover. Proper treatment, I think, in terms of 3 to 12 months for full recovery or decent recovery. It's a project, to get vaginal atrophy. It took years and years and years. To reverse it can take some time. So be patient. That's why you guys are called patients. And I have to be patient because I need to be patient. So be patient. The vagina will recover.
Yay!
With proper treatment. Yeah. And that will protect your bones. That's the minimal amount. You've got to have vaginal. And here's a question from Lee. I'm so dry from head to toe. Yes, you know what? It's not just the vagina that gets dry from low estrogen. The skin gets dry, the eyes get dry. Dry is the sine qua non, whatever that means in Latin. I think it's somewhere in the territory of low estrogen. Dryness everywhere. So, and recovery I don't know of a woman that has not had good recovery. Okay, to the levels of a 20-year-old, No, but good enough where a woman's going, wow, this is great. That's so amazing. I went on this program and I've been on it for a while. It took a while. It took 20, 30 years for it to decline. Doesn't mean, I'm patient. I'm a patient. I'm a patient patient. It will recover.
Yes. Thank you. If estradiol gets too high, will the body convert some of it to the androgens?
Not that I know of.
Okay.
And estrogen can get too high. How? Stress. 99% of the time. I'm not aware of an estrogen secreting tumor, but I've never encountered it and I've never researched into it. But women's estrogen levels can get too high, or they can be lower than they were when you were 20, but the progesterone needed to balance the estrogen isn't high enough to balance it. So there's two scenarios in which your estrogen can appear to be too high. One where it is too high, and the other is it's actually lower than it was when you were 20, but the progesterone that balanced it is much lower. So you don't get that exquisite balance. How does the estrogen get too high? Well, it's from the biology of the fight or flight response. So when we think of being attacked by a saber-toothed tiger, I think about it almost daily. I'm always looking around the corner. Is there a saber-toothed tiger around here? How about you, Carolyn? You do?
Yes. I've tamed them.
Because you never know what you're going to run into these days. So if we're attacked by a saber-toothed tiger, we're going to get a biology triggered in us that is going to be capable of making us capable of fighting or fleeing. I personally choose fleeing. You might want to think about this, folks, if you get attacked by a saber-toothed tiger.
Run!
Plan for this. So make a decision now whether you're going to fight or flee. Well, the biology is very profound, and you'll run faster and fight harder than you ever did imaginable. And what's going to permit you to do that is these powerful biochemicals that are the biology of the stress response or the fight or flight response. And at the vanguard of saber-toothed tiger attacks is the hormones adrenaline and cortisol. They do wonders. They've made women so strong, women have been able to lift a car off an entrapped child. And they're not the only hormones that are recruited for fight or flight. No way. Other hormones serve greatly because there's a lot of hormones that animate metabolism and animate someone. Thyroid, for example, major animator. So thyroid in the long run and chronic stress is going to be increased to help respond to the chronic stress. And so is estrogen. Estrogen is recruited for the stress response. It's a wonderful stress hormone. Where you can see it most evident is if you look at female Olympic athletes. A lot of these women are on tremendously stressful training programs. And a lot of them are not menstruating anymore because the estrogen that they're producing, instead of being able to go down the female pathway, it's heading down the stress pathway. So estrogen is recruited for the stress response. And so one mechanism of a younger woman getting elevated estrogen levels is she's got too much stress going on. It's not the stress. That's really to be emphasized. It's really to be stressed. It's not the stress. Let's stress that. That it's how we respond to the stress. Human life has stress built within it for very good reasons, amazing reasons. But it's how we respond to it. So we've got to acquire the wisdom, the tools, the information, the support to become better and better first responders. Because we are, by the way, the first responder to our own stress. So estrogen can be recruited and it can come out in elevated levels for a while, but you keep putting that kind of pressure on the ovaries, you're not going to be able to keep up with those elevated levels of estrogen. They're going to decline. And probably the more common thing that women encounter is it seems like There's excessive estrogen, and I mentioned this, of course, in this answering this question quite a few times, but I want to emphasize it again because it's the most common thing. You got a 40-year-old woman. She's got symptoms of overemphasis of estrogen, as if she has too much estrogen. For example, estrogen stimulates the uterus. Estrogen stimulates breast glandular tissue. And a woman in her 40s, out of the blue, can start having breast tenderness and PMS and cramping that she hadn't had for 20 years. A symptom of excessive estrogen. But the estrogen at the age 40 is much less than it was when a woman was 20, when it peaks out at 20. But estrogen is exquisitely balanced by progesterone, as I've said several times, even in answering this question. And if you and progesterone tends to decline earlier and deeper than estrogen. So even a woman 40 doesn't have as much estrogen as she had when she was 20. It's no longer being balanced by the progesterone, which declined earlier and deeper. And so it seems like she's got excessive estrogen, but she doesn't. She just lost the progesterone balance. And that's an easy remedy, by the way. Women in your 30s and 40s, you start getting breast tenderness or uterine cramping, your progesterone is declining. Get thee to some progesterone and use it. It's a wonderful hormone. So easy to acquire and be treated by.
You know, I want to save. Oh no, where'd you go? I don't know if you women can hear me. Can anybody write?
Lost
there
you
you
for
are.
a minute, sorry.
We're doing the disappearing act.
So you may think you have excessive estrogen, but it's really an imbalance, and you can address that with progesterone, but it's really more profound to acquire information and tools and support to deal far more successfully with the stress in your life. That's how people get wiser. That's how we all lead better lives, is if we acquire the information, the tools, the support through therapists, through groups like AA, or all kinds of groups, men's groups, women's groups. There's just a wealth of information and tools and teachers available to all of us. Online, there's a tremendous number of teachers. You can find the wisdom base that makes most sense to you, whatever it is. Acquire those information and tools to get more skilled at responding to the stress in your life. And what will happen is you get happier and wiser, and you'll have more fun, and you'll have more love, and you'll be more successful. That's the bottom line of that stress if you respond to it properly by going on a learning journey and going on a personal healing journey. That's the antidote for excessive estrogen levels. There's no medication to take to lower your estrogens or block your estrogens. It's get the message, folks. If you're having estrogen dominance, go out and get the information, tools, and support so that you can become wiser and a healer of your own emotions in your own mind. And that'll allow you to show up to be more present, and we get to experience this amazing life that we're in. We're alive. Holy mackerel.
Holy human.
Yeah.
So, a couple of questions came up that I'm not even seeing anymore. Okay. Let me get to this one. I cannot find any information about comparing doses. Can someone help? I was initially started on 100 milligrams of progesterone and 0.5 oral estradiol. The nausea was overwhelming. Day 6, I stopped the estrogen, and I determined that P is the culprit. I was just told that my doctor overdosed me on progesterone. I am told that 100 milligrams of cream is equal to 5 times of what I was supposed to get. Does anybody know where I can get a conversion chart for oral pills and capsules versus doses with cream? Thank you.
This is such an unusual situation we're dealing with here. Nowhere in the world of medicine or auto mechanics or any kind of professional field is there this degree of confusion where someone is forced to take on their own situation and they're just flailing to try and get answers. Almost any other technical situation, certainly in medicine and in auto mechanics and in millions of professions, you're dealing with stuff that it's better to deal with a professional. And you go out and seek a professional, and man, they know so much and they have so much experience. They've got 10,000 hours into the subject that you're meeting up for the first time. Well, not in the world of menopause. And questions like this are just epidemic still, because women can't necessarily reach out and meet up with knowledge and experience. And if you don't get it right with a woman, you can get into usually not hurtful situations, but situations that aren't working, and the woman is frustrated, and she reaches out to the medical profession, and they haven't specialized in it, so they don't really know the easy answer. So I know that that's not directly addressing her question, and I definitely will in just a moment. But it's just such an interesting thing in medicine, and it's a tragic thing. Well, we got a team that's really working on this. We are training physicians and nurse practitioners and healthcare professionals every day, and we just get bigger and bigger and bigger and bigger and bigger. And you want to find, and the bottom line is this woman, this is what you really need. You need to go shopping. You need to find a healthcare provider who cares about menopause and has really gone out of their way to get educated in it and to specialize in it even, so that you can get good at it. How do you become a good musician? Man, you put in 10,000 hours minimal. You may like music, but you sit down to an instrument, you got 10,000 hours to do minimal before you get into first base, probably. It's the same for menopause. There's no difference there. And here we have a woman she's got a case of one going, called herself, and her knowledge is minimal because she just can't go out there and acquire knowledge on how to do this thing. But let me address the questioner. 100 milligrams of progesterone is not a bad dose. It's a good dose. It's sort of right in the sweet spot. But there is no such thing as a sweet spot for any hormone, except for an individual woman. Because the range of, like I was saying earlier today, the range in my practice for women who dial in the right dose of progesterone, they get it. They get the right dose of progesterone and they feel it. And they go, hallelujah, this is amazing. They get the amazing dose of progesterone. Those that do that, in my practice, they range commonly in how much they're using from 75 milligrams to 225 milligrams. So 100 is not really off the charts there. But there are women who can't even tolerate 75 milligrams. They need 50 or 25 or even 5 or even 1 milligram. And there's women who need more than 225. There's nothing unusual about this. We human beings vary biochemically enormously, and the whole art of getting this right is finding the right dose for you as an individual. So the menopause method, for example, our bread and butter, the rock upon which we practice is individualized. Go woman to woman. There is no one dose fits all. And we start a process of starting low in any hormone that we're using to treat and gradually increasing with the intention of keep on increasing that dose until the symptoms a woman was having that relate to that hormone deficiency disappear. Or if we overshoot it and she shifts from symptoms of insufficiency to symptoms of too much, we back down. It's dose determination by titration, it's called. Dose determination by starting on low doses, gradually increasing, alleviates symptoms of insufficiency, And if you go too high and you get symptoms of overdose, you back down. So this is what this woman needs, is someone to guide that process. I'm not at all concerned about 100 milligrams. It's sort of smack dab near the middle of what most women in my practice choose. But think of the range, 75 to 225. And then some are lower and some are even higher than that. Now, there was a second part to that question, Carolyn. I missed it.
Well, she's saying that she was told that 100 milligrams of cream is equal to 5 times the amount of what she's supposed to be getting.
Yeah, I don't get that at all. I think I would call that total 100% wrong information. We don't know this. Creams, I love progesterone. Well, we love progesterone in organic oils base, not a cream base. But creams can do a decent job. We care about this, though, a lot. Those creams are solvents, so we don't like to administer solvents. But, if that's the best thing you have, you use it. But when you say 100 milligrams, it is possible to make progesterone 100 milligrams per milliliter, so it also depends how much you're taking. So I'm going to say a milliliter probably. That's not a humongous dose at all. I've chosen that dose many, many times, but it's irrelevant. I can hardly comment on the dose because there's some women who they do terrific on a cream that has 18 milligrams per day. 18 milligrams per milliliter. There's others that need 200 milligrams per milliliter. They need 200 milligrams. And there's everyone in between. And it's an individual thing. And 100 milligrams per milliliter progesterone cream is good stuff. And then there's also progesterone that you can take, unlike estrogen and testosterone, which I advise against taking orally. And that was the second part of that question. There was an error this woman was making. If the only estradiol I had in the world was oral, I would use it. But I wouldn't. But I never use it. I only prescribed it once in my entire 25 years, oral. It was for someone who just couldn't manage the topical. They had too much cognitive challenge. But every single other case for 25 years, we use topical estrogen. We don't use estradiol. We use Biest. But if all you had was estradiol, well, that's good. Use it. But estrogen is delivered topically. There's reasons. Oral has some problems associated with it. It can stimulate inflammatory proteins in the liver. It can stimulate things that enhance coagulation. No one wants to enhance coagulation. You don't want to get any clots inside of your veins or anywhere else. So oral estrogen is just, we just don't ever use it. One exception. So that's the other part of that woman's question that I wanted to address. And lo and behold, wouldn't you know,
It's the bewitching hour.
is come upon us.
Green screen en route. Have a great weekend, Dr.
You too, Carolyn.
Thank you so much.
Thank
Thank
you.
you for being here. Ladies, I'll get your questions. I'll get to them. Thank you for being here. Have a great weekend. Everybody enjoy. We'll do this again on Tuesday, but the 23rd not, right?
Right. 2 days before Christmas, there will be no Facebook Live.
But there will be a Christmas.
Oh, yes, there will.
Just wanted to
Though I
make
don't
sure.
have too much control over that one. Maybe you do, Carolyn. It's more up your personality. You may be in
I'll
charge
make
of
sure there's
Christmas.
Christmas.
Are you in charge of Christmas? I think you could be.
Indeed, I am.
That's
So
right.
there will be one.
All righty.
Okay. Everybody enjoy. Bye. See ya.
Bye-bye.